Welcome to this webinar. It's the first of two webinars about the research program Assembling the Data Jigsaw. Today we're focusing on clinical questions. We're going to start with a brief overview of the research program, and then we're going to have three short talks, each of which are a distinct clinical question. We're then going to be joined by three expert discussants who will share their reflections of the work, and we're really grateful to Roger, Dale, and Jose Luis for joining us and taking time out to read in advance what we've prepared and sharing their reflections. We will give you the chance to ask questions, but there's a Q&A box. If you submit questions as you think of them, we'll take all of the question and answers at the end of the hour session. And the last thing to say before we start is that we've developed some animations to try and convey our work to a wide audience and to show how the various different parts fit together. So particular thanks to Charlotte Sharp for the idea around this, Louise, Angela Roche for presenting them, and you'll see those dotted through the talks. So I'm going to start by sharing the slide deck. Alice, you're the face that I can see. Can you just nod if you can confirm you can see that? Yeah, great. Thank you. So the overview of the program is that we know that routinely collected electronic health record data is collected primarily to support clinical care, but there are additional opportunities that same data can support research and other purposes. There are, however, limitations that come from the availability and the quality of that data. And really, arthritis research exemplifies many of the different health data problems. There are four that we focus on in Jigsaw. The first is that the information that you might want is absent or missing. It just doesn't exist in electronic health records. The second problem is that the coded information that is in EHRs is inaccurate. So here you can see a picture of nodal osteoarthritis, and yet the code that exists in the GP record is M06.9 rheumatoid arthritis. The third problem is that lots of the information held in electronic health records is unstructured. So that might be the pictures that you get from imaging. But in rheumatology, all of our information is held within outpatient letters that are really just a bag of words and are not machine readable. And the fourth problem is that data are sometimes siloed. You have all of the ingredients that you need, but half of the ingredients are in one place and half the ingredients are in the other. So if you want to know what is the burden of social care for people living with arthritis, the social care data set has information on social care, but doesn't know if people have arthritis. And the health data knows that somebody's got arthritis, but doesn't know what social care they've had. So Assembling the Data Jigsaw is a research program that we put together in response to a call for local data integration pilots. It's designed so that we pilot the novel collection, extraction, and integration of different types of data in rheumatology, but done so in order that we can answer important research questions, which we'll hear about in more detail today, all of which we've designed to ensure that we maintain public trust and to ensure the sustainability and scalability beyond the pilot. The webinar next week is going to be focusing more about the data and the public trust. Today, we're focusing on the clinical questions. The data sources that we've used in the program include primary care electronic health records, outpatient hospital letters, inpatient prescribing and inpatient events, web-based surveys, social care data, as well as interviews and focus groups. The clinical questions, though, our focus for today, three examples of this that we'll be hearing about are the use of opioids at home, in hospital, and the transition from one to the other. And we'll hear from Meghna in a second. The second clinical case study is about identifying as yet undiagnosed axial spondyloarthritis that John and Alice are going to present. And then thirdly, we're going to hear about social care use in people living with arthritis presented by Jenny. And as mentioned, we've got three experts to share their reflections. Roger Nagg, the president of the British Pain Society, Dale Webb, the CEO of the National Axial Spondyloarthritis Society, and Jose Luis Fernandez, Director of the Care Policy and Evaluation Centre at the London School of Economics. So many thanks indeed to the three of you for sharing your thoughts today. So here's the first of the animations that really just summarises what we're trying to do in Jigsaw, and then I'll hand over to Meghna. Share. Well, share. So we've just heard that you couldn't hear the sound on that. There wasn't a voiceover, but there was music, and that's our setting. So we'll fix that. But I'm going to stop sharing and hand over to Meghna to give us the first talk about opioids. Thanks, Meghna. And just a reminder, whilst Meghna's sharing her slides, please do put questions in the Q&A button if you have any during the course of these three talks.
Thanks, Will. Can you see my screen? Yeah, okay, great. So hi, everyone. Great that you could join us this afternoon. So my name is Meghna Jani. I'm an NIHR Advanced Fellow and a Senior Lecturer at the University of Manchester. I also am an Honorary Consultant Rheumatologist at Salford Royal. And within the programme, I lead the work package on analgesics. So as a number of you will know, that prescription opioids have been associated with a major epidemic in North America, and there have been concerns about prescription opioids increasing in the UK. We know that they're associated with a range of different adverse events, from premature mortality, respiratory depression, delirium, and constipation. On the other hand, we know that they have limited effectiveness, particularly in the context of musculoskeletal indications. And some recent work that we've published has just shown that musculoskeletal conditions are, in fact, some of the most common indications for prescription opioids in the UK. So reducing opioid prescribing for non-cancer pain is, in fact, a national NHS England medicines optimization priority in 2024 and 2025. And the reason why that's especially of interest to us in Greater Manchester is because Greater Manchester also happens to have higher opioid prescribing compared to the national average. And also when it comes to adverse outcomes, unfortunately, the Northwest has one of the highest death rates related to opioids. So we're the second highest in the Northwest, just after the Northeast across England. So a number of you will know that a lot of information and data available in this space tends to come from primary care electronic health records, so well-curated data sets such as CPRD and Open Safely. However, what often tends to be missing is what's happening in hospitals in terms of use and safety, and also what patients are taking at home, which, as you can imagine, is not captured using electronic health records. So as Will was saying, that data tends to be completely absent. When it comes to hospitals, we know that this data, even though it might be electronic, is not well curated for research and therefore often siloed. So within the Data Jigsaw program, we had the opportunity to address some of these questions. We had the opportunity to address questions around over-the-counter or internet use of pain relief supplements and sleep aids. We were also interested in addressing questions around hospital use and safety of opioids. And we also had the opportunity to address questions about key transitions of care, such as from hospital and back to the community and at discharge. However, in the interest of time, I'm going to specifically focus on just hospital and home today. So one of the key aims that we were interested in was to assess the use of over-the-counter supplements, analgesics, and sleep aids in rheumatology. And the background to this is that supplement use has increased considerably over the last 40 years. And whilst patients with musculoskeletal conditions are often on DMARDs or disease-modifying treatments, we know that they often experience breakthrough pain, poor sleep, and fatigue. And non-pharmacological options, such as physiotherapy, for example, that might help with this can sometimes be difficult to access. So it's understandable why patients might be looking for alternative treatments to help with some of these symptoms. So to address this, we developed a survey with the input from an interdisciplinary team and a patient advisory group. We recruited and consented 876 patients from Salford Royal Hospital over 2 years, and we performed an electronic survey. So patients were able to fill out this survey through their smartphones while they were waiting for their appointment to see a consultant or a healthcare professional. And they could also fill it out as a web-based survey whilst they were back home. And so some of the key findings were that we found that 82% of patients took some form of pain relief, whether it was prescription, over the counter, or borrowed from a family member. And of these, 20% took an opioid. So the majority of these were prescription, but 1.5% of patients borrowed these from a family member or took them from over the internet. In terms of supplement use in rheumatology, the majority of our patients, 55%, took supplements daily. 1 in 5 took more than 5 supplements daily. And in terms of cost per month, we found that there were patients who were spending up to £200 a month. However, the median cost was around £10 a month with an interquartile range between 5 and 20. The most common supplements that patients reported were vitamins, so vitamins D, C, multivitamins, B complex, omega-3 and 6, turmeric and magnesium. However, importantly, there was a large overlap between supplements that could potentially increase their recommended daily allowance. So for example, being on a multivitamin and a B complex tablet at the same time, and also an overlap with other over-the-counter medicines and supplements with potential interactions. So some of the key points here was to raise awareness of this with people who take these supplements, but of course, to also ask healthcare professionals to proactively ask about supplement use in their consultations. And if you're interested in this, we recently published the final version of this paper just last week as an open access publication. So to extend some of this work as part of a separate work package, which was led by Sabine van der Veer and Susie, they looked at the feasibility and added value of measuring medication patient-generated data over time. And so to assess this, they recruited 36 patients from our rheumatology clinics, and patients essentially entered information about their over-the-counter supplement use and opioid use over 6 months. And what they found is that patients felt that there was value in reporting frequency and use, especially for as-required medications, which might not be captured in electronic health records. And interestingly, 88%, so 32 of the 36 patients reported side effects that are not measured or captured in electronic health records and clinic letters, such as constipation and indigestion. So moving on to hospital prescribing. So whilst I mentioned that there was an increase of prescription opioid use in the UK, we know that there are limited options for pain relief. And opioids can be helpful, particularly in the short term, especially in acute contexts, so for example, after surgery. So there are multiple different opioids available. However, which is safest in what context, given their different pharmacology, often tends not to be clear either for the healthcare professional or the patients taking them. And we know from our own experience as healthcare professionals that constipation is perhaps one of the most frequently reported adverse events to opioids. However, tends to be underreported in most studies because often the coding tends to be inconsistent. And it also has a major impact on the quality of life and activities of daily living in people who are affected by this. So to address this question, we use data from Salford Electronic Health Records, which is one of the longest running digital electronic healthcare health record systems in the country. It was also previously a global digital exemplar. So in epidemiology, we tend to talk about the effect of the exposure on the outcome. And as I mentioned, this tends to be typically from primary care electronic health records. However, so typically when we're using this type of data, this comes from electronic prescription data, and the outcome tends to come from read codes or ICD-10 codes, which are essentially codes that a GP will enter when they make a diagnosis. However, as part of this study, we had opportunity to measure both of these slightly differently and more accurately. So we had access to dispense data, so whether or not the patient, in fact, was administered the opioid drug, which allows us to measure exposure much more accurately than we would be otherwise. And the outcome this time was severe constipation, so whether or not someone was administered a suppository in hospital. So the aim of this piece of work was to assess the comparative risk of constipation in patients treated with opioids for non-cancer pain in hospital, and to specifically quantify this risk by both type and dose of opioids. So we performed a retrospective cohort study between 2009 and 2020, adjusted for baseline confounders, and in total included around 80,000 patients that met the eligibility criteria. So these are the key results. So what we found is, in comparison to codeine, that patients on tramadol had a significantly lower risk of the outcome, while patients on stronger opioids such as morphine, fentanyl, oxycodone, and combination opioids had a significantly higher risk. Specifically, we also found that there was a dose effect. So patients who were on 50 or more morphine milligram equivalents per day had a significantly higher risk of the outcome compared to those on lower doses. So in summary, we felt that these results can help better guide decisions when patients do need to be on an opioid, but can also help prompt discussions about opioid tapering in those patients who do have the outcome. So I'm going to finish there and share with you a video that was developed by our comms team, which will hopefully put some of these results to life. So Will, are you happy to share?
Yeah.
Sorry. You can share
that. Please let me know if the sound doesn't work this time, but hopefully it will.
Yeah.
Great. So thanks very much indeed, Meghna. So I'm going to invite Roger just to say a few words of reflection about the findings from Meghna's work. Thank you.
Thank you. And thank you, Meghna, for your presentation and the research in both of these topics. They're both extremely important for both patients and clinicians. With regard to the supplements, your study shows that the use in people who are attending a rheumatology clinic is relatively common. And I think a couple of things really stand out to me in relation to this. The first relates to the fact that prescribers should ask routinely about the use of supplements and vitamins. That's something that pharmacy students are or taught when taking a medicines history, but is perhaps less thought of by other professionals. So I think there's an issue around people rethinking their consultation to include this aspect. The other relates to the potential interactions with prescribed medicines, and that prescribers need a reliable source for being able to look at interactions of these supplements with prescribed medicines. There are some available, but they are not available to many clinicians. And I think this is, at a national level, perhaps something that needs some thought in terms of is it something that should either be included maybe in the BNF, or also more information in the regulatory information, such as the summary of product characteristics. In relation to the study on constipation and using hospital records, we all know that constipation is a predictable side effect, but it's very often overlooked and poorly managed. And there's relatively little research that has actually looked at its incidence in the secondary care population. So I think this is certainly a novel aspect of that study, and also what the impact of constipation whilst somebody is an inpatient. Clearly, the key messages here are around the impact of dose and also different opioids. And I think the key issue here is how this is then translated into guidance, both at a national level and perhaps inclusion in resources such as Opioids Aware, which is a national resource for prescribers around opioids, and also how it fits into local guidance as well. So I think but it's also important to highlight the impact that gastrointestinal symptoms have for people who are taking opioids. And although constipation is very often the symptom that's thought of, there are a much wider range of gastrointestinal symptoms that people may experience, such as abdominal cramps, spasm, bloating, and this really creates what is sometimes being described as opioid bowel dysfunction, and perhaps this needs to be thought of in a wider context.
Roger, thank you so much for those reflections. It's really interesting and informative to hear about. So just a reminder to everyone that you can put questions about that presentation in the chat. We'll try and answer them as we go along, because we will be tight for time at the end. But let me move on now to the second presentation from John McBeth and Alice Jules about as yet undiagnosed axial spondyloarthritis.
Okay, thanks, Will. I'm John McBeth. I'm a professor of epidemiology at Manchester, and I'm going to co-present this with Alice Jules, who's a data scientist at IQVIA. And this piece of work really is interesting in that it brought together the expertise of the data and data linkage that we were working on at Manchester with the skills that Alice and her team bring in mining that data and understanding unique patterns within it. And the clinical question that we were addressing was around axial spondyloarthritis. So axial spondyloarthritis, or AxSpA, is a form of inflammatory arthritis, and it mainly affects the back, the main symptom being back pain. Over time, axial spondyloarthritis can cause some of the bones of the spine to fuse together, and it can also affect other joints, so other joints such as hips, shoulders, and knees, as well as tendons and ligaments. Axial spondyloarthritis is common. We estimate about 1 in 200 people in the UK actually have the condition, but those numbers are a little bit unclear, because we know that there's a long diagnostic delay from first symptom presentation, usually in primary care, up to receiving a diagnosis of axial spondyloarthritis. And on average, that delay can be up to just under 9 years. The delay is largely due to the non-specific nature of those early symptoms. So lots of people may present with back pain, and the majority of back pain will be non-specific. So it's hard to pick up amongst all of those presenting with back pain, those who may have axial spondyloarthritis. And there's also a lack of widespread awareness among healthcare providers. Saying that, axSpA has widespread impacts on those individuals who have the disorder. So it impacts on physical health, causing pain, stiffness, and fatigue. It is associated with increased rates of mental ill health, including anxiety, depression, and distress. And it also impacts on many other areas of a person's life, so their work life, their social life, and significantly can reduce quality of life. Next slide, please, Will. So I mentioned some of the symptoms of axial spondyloarthritis. It's important that when we're thinking about how we may be able to identify this early, we understand what those might be. So chronic back pain being one, but there's also other symptoms: morning stiffness, fatigue, joint pain, as I mentioned, inflammation in the tendons and ligaments. But there's also other symptoms of inflammation, including in the eye, skin, so disorders such as psoriasis, and inflammatory bowel disease. It's a progressive disease. It occurs over time and potentially can lead to spinal fusion and loss of mobility, as I mentioned, although that's not the case on all patients with axial spondyloarthritis. But it's clear that early diagnosis is important. People that are diagnosed early and treated early have less damage to the spine, and research shows that they report better mobility, less pain, less anxiety and depression, and have an improved quality of life. Next slide. So in the Jigsaw study, we were interested in understanding primary care data to identify individuals who may be as yet undiagnosed with axial spondyloarthritis. But our immediate goals in this study were to identify factors recorded in primary care data that predict axial spondyloarthritis that's been diagnosed in secondary care. And this was to build a predictive model that we could validate in later stages of the study. We want to do that based on the factors that I've described, and we want to develop and assess the effectiveness of the algorithm to predict axial spondyloarthritis, as I said, diagnosed in secondary care. Longer term, if we can do that, and if the algorithm is valid and reliable, we would look to firstly scope opportunities to test if the algorithm correctly identifies people who are undiagnosed in primary care in this case, and deploy the algorithm in primary care to identify those patients. So what data do we have? Well, we have two sets of data, as Will introduced very clearly at the beginning of the webinar. We have hospital data and primary care data. From hospital data, we've accessed outpatient letters, and using text mining methods, we've identified patients who have been assessed at secondary care and have been given a diagnosis of axial spondyloarthritis. And from their outpatient letters, we've identified that diagnosis and also the date of diagnosis. We've then linked to those patients their primary care data, and along the bottom you can see a typical patient's medical history prior to their diagnosis. There's lots of complex data that sits within primary care data, so tests and diagnostic procedures, symptoms, comorbidities, amongst many others. By linking that data, we're able to assess whether or not there are patterns within the primary care data that would predict the secondary care diagnosis of axial spondyloarthritis. And we do that by comparing those patients to a control group of patients. And so for the methods, I'm going to pass you to Alice, who will describe those.
Thanks, John. So I have the honour of explaining exactly how we're investigating the use of AI to reduce diagnostic delay for axSpA, as John has been describing for us. And I'll just go into a little bit more detail about this. So we've all heard of AI, and the AI that we're talking about here is going to be delivered through an algorithm, otherwise known as a model or machine learning, but it's essentially a set of instructions. And we want to write these instructions that find patients who are undiagnosed with axSpA to speed up their diagnosis and reduce this diagnostic delay. So, as John was describing, and as I've written in the top left-hand side box of this slide, these instructions are going to be learned from GP medical records, as well as hospital data, which tells us whether or not a person has a diagnosis of axSpA. So how exactly does the algorithm work? And this is described in the bottom left-hand side box just here. And again, as John was saying, the algorithm searches for patterns in GP records that are commonly found in patients with an axSpA diagnosis. And it learns these patterns so that in future, if we were to deploy the algorithm into clinical practice, we could look for these patterns all over again and find patients whose GP records look like those of the patients who have an axSpA diagnosis. And we want to do this so that they can sort of go down the referral route and understand if they do indeed have axSpA. So, top right-hand side box, what exactly will the algorithm tell us? And at the moment, there's lots of different ways that we could use this algorithm, and we're still working it out. But one of the options would be that an algorithm could be used by a GP. It could then rank patients who are registered with a GP practice in order from those who the algorithm thinks are at highest risk of having undiagnosed axSpA down to the lowest risk, so that GPs can look at these patients themselves. And finally, I'm going to speak about the bottom right-hand side box. And this is a really important topic because what we're talking about here is fairness in AI. Is the algorithm safe and is it appropriate? So I think the biggest thing that we're talking about here is that regardless of someone's demographics or their income, perhaps so ethnicity, race, any disabilities, any kind of factor that can be associated with a human, we want the AI algorithm to know if that patient potentially has undiagnosed axSpA, regardless of all of these characteristics. And this is a big topic in AI at the moment, and it's really important that us data scientists and AI engineers are building our machine learning algorithms such that no systemic biases against these individuals are learned from the data, so that we're making fair predictions with our algorithms. So that's all from me.
So thank you very much, John. Thank you, Alice. And I'd like to invite Dale just to give some reflections of this work in context of the wider work that they've been doing in the National Axial Spondyloarthritis Society, particularly around diagnostic delay. Thanks, Dale.
Oh, many thanks, Will. I think the value proposition here is considerable. I've got three comments, really. The first is that we know that the impact of delayed diagnosis is vast and considerable. We have recent systematic review showing that where we have greater diagnostic delay, patients have greater functional impairment and worse quality of life. We also know through some recent economic modeling that we commissioned that if we could reduce the time to diagnosis to just 1 year, that would save the average patient £167,000, mostly through productivity gains, but there are also savings for the NHS. So reducing diagnostic delay is good for the patient, it's good for the NHS, and it's definitely good for the broader UK economy. My second point is we now have some new data where we've mapped out through 600 patients from almost 60 trusts their journey to diagnosis from symptom onset onwards. And we know that more than half of the time to diagnosis is spent within primary care. It's 53%, which is an average of 4 years and 4 months. And our data also show us that 2/3 of patients, these are newly diagnosed patients, have seen their GPs multiple times before they've been diagnosed, with an obvious correlation that those with the highest number of GP visits are those with the longest time to diagnosis. So my third point echoes what John said at the start, which is the importance of separating the signal from the noise. We have 20% of the population who have chronic low back pain, and about 80% of the population will at some point in their lives have back pain of some sort. So identifying inflammatory back pain amidst the more common mechanical causes can be very challenging for our primary care professionals. And we've seen, I think, in recent years, some focus to try and look at this within primary care. We've seen the use of referral support tools, so the Prime Risk pop-up tool, the use of the SPADE tool, changes to the Ardens templates, as well as a greater focus on primary care education and pathway development. But having a predictive algorithm to prioritize patients for referral, I think could significantly reduce the time to diagnosis. So I'm excited to see what comes next from all of this.
Thank you very much indeed, Dale. That's really good to hear that it's such a clinically important area, and we hope that this will indeed make a difference in the future. Thank you. So I'm going to hand over to Jenny for the third clinical research question around social care. So Jenny, over to you.
Hi everyone. Good afternoon, and thanks for letting me speak on this. I'm just going to mention Paul Clarkson, who has led a lot of the work on social care outcomes, and Susie, who's also been involved in the patient-generated health data. I've clicked. Oh, the slide moved on when I wanted it to. I'm not sure how that happened, because am I running the slides?
No.
Okay. Well, anyway, that's great. So, for a bit of background, rheumatic and musculoskeletal diseases are the second most common driver of years lived with disability globally, according to the WHO GBD study. And despite advances in treatment in some of these diseases, many patients still need help with their activities of daily living. And that's what social care is. And it can be both formal and informal. Formal is provided by governmental organisations and paid care, and informal by friends and family. Now, that formal care may be captured, say, in the UK by local authorities, but informal care is very rarely routinely captured. Next slide. So social care studies in Jigsaw, it's run across several of the different work packages, and today I'm going to talk about mainly about the cross-sectional survey, and then a little bit at the end about our planned work for routinely collected social care data, and I'll just make one small mention of the patient-generated health data. So this first study that I'm going to talk about aims to characterize and quantify social care in people with rheumatic musculoskeletal diseases in two different parts of the UK, one rural and one urban, and these two different types of social care, as I've mentioned before. Next slide. So the study was set in Salford, with unselected adult patients attending the Salford Royal Rheumatology Outpatient. That was our very urban setting. And then in Norfolk, we invited active participants of the Norfolk Arthritis Register to take part in the research. The Norfolk Arthritis Register is a very long-running study observing patients with inflammatory arthritis, so slightly different patient groups as well. Next slide, please. So we collected data through a Qualtrics survey. This ran alongside Meghna's opioid cross-sectional survey as well. But the survey that we used for this was based on a pre-existing social care interview survey that we've used previously, adapted in this form as an online survey. There was information collected on demographics, whether or not people had help with their activities of daily living, which activities needed help, who provided that help, and the type, frequency, and duration of care they received. So in terms of the analysis, this was primarily descriptive, although we did conduct a logistic regression model to look at factors associated with the receipt of help with ADLs and adjusting for these covariates you see here. Next slide. In terms of the results, This is just very brief demographics, age and gender. So from this, I'll just mention that you can see between the two cohorts, Salford and Noir, the patients in Salford in Noir, that's Norfolk, were slightly older, but very similar split between male and female, and not much difference between those who received help and didn't. Next slide. So in terms of who provides care, and I guess this is really the key finding, what we see in both cohorts is that the vast majority of care provided comes from family members and then friends and neighbours. So very little care was provided to either groups by home care or by the local government. A few people had some help from a cleaner or from occupational physiotherapists. Next slide. And then in terms of how this care was distributed, and I'll just apologise for the bars of missing data, which kind of slightly come in different places here. So just to summarise, what you can see is that the majority of people was receiving care for several hours per week. A very small number had a really, really intense amount of care received, and most either daily or weekly. That's across both cohorts. And what we don't see is that those people who seem to be receiving more care, maybe requiring more care, that those are the ones that are getting it formally. You might think that people who had a higher care burden might be receiving the formal care, but that's not what comes across in the data we collected. So next slide, please. And in terms of our regression model, the key finding here is that patients who had more than one long-term condition alongside their musculoskeletal disease were significantly more likely to require care, either formally or informally. So next slide. So just to kind of discuss these findings, there's a really high proportion of informal care, and this has been talked about quite widely, that this has a massive unseen impact on the economy, both the person themselves, but their carers, and that this is just a sort of hidden from society. And especially given that most adults are now working, we don't have the older model where there might be one person in a family who is a caregiver, that this can be a significant impact. So the presence of multiple long-term conditions was associated with increased likelihood of receiving care. And we know from other work that actually the musculoskeletal disease can be the real tipping point in terms of disability. So when people have multiple long-term conditions, it's when you get an MSK disease, that's what tips you over into problems functionally and with conducting your activities of daily living. And these findings were pretty consistent across our two very different urban and rural settings. So I'm not going to mention the patient-generated health data study. I think that's going to be talked about more in the next webinar. But just to mention one thing that came out from that. So this was asking patients whether or not they would be happy collecting data on what care they received on a regular basis through an electronic device of some kind. And there was a quote from one of the patients that said, informal help is taken for granted. And I think that's probably a message that we see throughout this. So just a final couple of slides on work that we're planning to do in study 3 here. This is to understand the proportion of rheumatology outpatient attenders that use council-funded social care services. And we want to know if this varies by MSK condition. We want to know whether or not some of these patients are also receiving informal care because the council collect that data, which activities they need help with, and if possible, the costs of social care for patients in this group. And this is going to be done by creating a linked data set of secondary care data from Salford Royal and an extract of social care data from the Salford City Council. And again, this is going to be primarily descriptive analysis. So this study really highlights some of the challenges that we've had across Jigsaw. We've been trying to get approval and governance approval for this study for over 5, coming up to 6 years now. And this slide just takes you through some of the hurdles that we've managed to make it across. And we're really hoping that we will gain access to the data and be able to start doing some analysis in the new year. So that's all from me, but I think there's going to be a little animation for you now.
So thanks very much, Jenny. And we'll just invite our third discussant, Jose Luis, just to comment on some of those findings. Thank you.
Thank you very much. Can you hear me okay?
We can. Fine, thanks.
Brilliant. Okay, so thank you very much for that very interesting presentation and study. I'm going to make a few points. Some are about the use of data, I guess, of this type of administrative data, and others are about more specifically the sort of the analysis carried out. Because I think one of the strengths or one of the potentials of this study and these types of study is to help us, first of all, understand how we should use administrative data when we go in and by the way, I totally share the pain about how long it takes to get this type of data, which makes any application for funding almost by definition a lie in the sense that you're going to end up taking 2 or 3 times longer than you think to get the data coming to us, and therefore all the delays. I think we do need a very, very important objective for all of us who are working in this area and using administrative data is to achieve a change in the regulatory framework so that these processes take much less time than they do currently, because it's undermining research in a very serious way. But anyway, apart from the sharing the pain, I think it's really important that we use some of these studies to help us improve our use of this data, because it's very important to recognize that the data that has been collected, for example, by social workers through assessments and in general the administrative data, and I work a lot with social care administrative data, is not collected for the purposes of research, and is not collected for the purposes of evaluation. And therefore, we need to learn how to interpret and how to use this data most effectively. And just to give a few points around this, one is that the really local authorities will be collecting this data either because they have got some true desire to use the data in order to understand how their systems work and how they provide care, or because they have to collect the data. And that often, in my experience, has led to, for example, in particular data about the characteristics of individuals to be collected when it's relevant for the purpose of social care. So, for example, many authorities where I've used their assessment data would have things like long-term health conditions, but diabetes is never going to be recorded unless diabetes is leading to something which is having an impact in terms of the social care needs of the person. So, you know, in using this data, we need to learn how to interpret it in a relevant way. And given that you are collecting data from different sources and you're able to compare, that I think should be a really valuable output of the study, just to understand the reliability, but also the way in which data is collected in different parts of the system for different purposes, and how that affects us in terms of wanting to use the data for evaluation, but equally to understand the extent to which professionals using these data at the front line are well informed or not. So, and I was struck, for example, by the amount of missing data in one of the areas. Well, you know, so how do we deal with that? You know, what does that mean both for the area as well for us using that data? So that's one set of points, I guess, which is about the use of this data. Very interesting to see that you've got data on a number of hours of unpaid care, and there's all sorts of analysis that I wonder whether you're going to be able to do, looking at the extent to which social care packages are reduced when unpaid carers are there, because in England, local authorities certainly can take into account the amount of unpaid care that is being provided in order to set the amount of formal care that they provide, and that's a very important policy question. Of course, there will be a lot of it would be really interesting to understand who is providing that unpaid care, because there'll be a lot of spouses of perhaps people who are retired, and therefore that is also important in terms of thinking about the implications for the economy. But as I say, also comparing the information that is in the NHS, once you get the data, hopefully in January, comparing the two data sets is going to be really, really important to understand, the potential to improve information, but also whether some of the information is really inaccurate, which I believe is going to be the case. And then the other thing I was going to ask is, you've got administrative data by definition are very important, very powerful in that they've got longitudinal data, because you can follow people through time backwards, as well as, are you going to use that? Are you going to do longitudinal analysis? Because I think that would be really, really interesting. Thank you very much.
Thanks, Jose, with really helpful reflection. And it's going to be interesting, isn't it, as to whether the landscape does indeed change, particularly following the recent Sudlow review of the use of routinely collected data in the UK. So we're surprisingly on time. We've managed to pack lots of information in the three talks and the three discussants' comments. I think the team have done a great job of responding to the questions as we've gone along. So many of them have been answered by in the Q&A box. You are able to raise your hand. So if people do have additional questions, please, or even reflections, please do raise your hand up and we can unmute you and see if we can answer those remaining questions. Whilst we wait for hands, let me just have a quick scan of the Q&A box. There is one question that's unanswered, so let's take that one for now. A question about unstructured data and trust. A question about unstructured data, how electronic patient record notes and letters, would it be possible to elaborate on the current limitations and going forward, how to fix these? We're going to cover that to an extent in the second webinar next week. The second question is about patient-public trust. And again, actually, we're going to present that next week. So I'd refer you to next week's webinar. Anyone in the audience have questions that they'd like to raise? I don't think I'm missing any hands up. No? Okay. In which case, I'm going to thank a few people, because it's been a lot of effort to get this program delivered. All of the Jigsaw team, there's a large group of researchers, so thanks to everyone who's contributed, particularly thanks to the hard work behind the scenes from Louise and Ginny, who are here with me in the room, Elaine and Rachel, who've led all of the information governance that makes it particularly challenging to do this type of linkage work. I'd like to thank colleagues at the Northern Care Alliance, Karim, Webb and colleagues. Karim will be joining one of the panels next week. Really like to thank our public contributors, a few of whom are on the call today, Russ and others. So thank you very much indeed. You've helped us enormously in defining our research questions, showing that the work that we're doing has importance and relevance. And lastly, I'd really like to thank the funders, the Oliver Bird Fund, administered through the Nuffield Foundation, as well as Versus Arthritis. So thank you all indeed for coming along to the webinar. We hope you found it interesting. The second webinar next week, we're going to be covering 3 issues around the data specifically. So the first about public trust and how did we run a public notification campaign of what we were doing and inform the residents of Salford. We're going to look at the text mining, the outpatient letters, and how we can understand the extent of misclassification in primary care. The third talk is going to be about how we have thought about collecting structured information from rheumatology services rather than needing to do text mining. And then we'll finish with the lessons learnt of doing a local data integration pilot. So expanding on that final slide of Jenny's, which shows you a 4-year period where it has been continuous effort to try and do what might seem like a relatively complex linkage, but we're trying to learn lessons from why is it so hard and how can we make it easier in the future. So thank you very much to the speakers. Thank you to the discussants in particular. And we hope to see you in a week's time. Thank you.
Thanks,
Bye-bye now.
Bye.